right, everybody, welcome. This is the Millennium team. We're going to be going through the Medical Neighborhood webinar today. We appreciate you taking the time to join us today. And we have a lot of presenters at the table, so just bear with us as we move through the presentation. You're going to be hearing a lot of different noises and voices. So I'm going to let everybody introduce themselves in the room here at Millennium. I'm Sarah Wangai. I'm a relationship manager for the primary care clinics, and then I'm going to go in this direction.
Hi, this is Nicole Aloisio from Millennium. I'm a care coordination assistant here.
Hi, this is Ezra Mustafa. I'm a clinical pharmacist here at Millennium.
Latanya Diggs, behavioral health manager.
Laura Kennedy, relationship manager.
Good afternoon, Kim Backey, community engagement manager.
Hi, this is Sarah Lynn Tiedman, a post-acute and acute care relationship manager. I believe I'm going to be talking about the first couple slides. The next slide, please. All right, so you should be looking at just a few bulleted items of reminders just for this webinar presentation. So we will have the audience muted for the duration of the presentation. Please submit any questions or comments you have in the chat portion of the webinar. We will open the phone lines at the end of the presentation for a group discussion. Attendance will be taken based on the individuals that have signed into the webinar. If you are listening in a group and there's multiple people listening to one phone line, please just email your respective relationship manager with the group names that were in attendance to the webinar. Please do not put your phones on hold. As much as we love your office music and your advertisements, it really tends to interrupt the presenters. So if you could please not put us on hold, we would really appreciate it. And we will get going to the next slide. So the agenda for this presentation, we're going to do an introduction and a background of the medical neighborhood concept and methodology, discuss the objective of the medical neighborhood, talk about some of the MPA deliverables that both the acute care partners and the primary care partners have in relation to the medical neighborhood, which is the development or use of a risk tool, having a really thorough care coordination policy, as well as a care transition plan. We're going to speak about a couple different potential key relationships that could be in your medical neighborhood model. Speak to the support that Millennium can lend to help develop your model or make it even more comprehensive than it may already be. We're going to speak quickly about BDP and its relationship to this model and then discuss next steps. Next slide.
All right, great. So we just want to discuss a bit of an introduction and go through background about the medical neighborhood. I'm not going to read everything on the slide, and you all could refer to these after the presentation. But essentially, we are here to discuss how our patients access the healthcare system with little or no coordination between different health systems.
Just a reminder, if you could put your phones on mute. We are getting some background noise. Thank you.
Again, as I said, we are going to be discussing how many of our patients today are accessing the healthcare system with little or no coordination between them. And this just leaves our patients with lack of understanding about how to navigate this complex system. And then we just want to really look at how many of our patients and their families have little understanding about how their primary care physicians and offices coordinate with other clinicians, organizations, and institutions, and how we all could enhance those in order to create a better neighborhood and just help them understand more about the system, how it is organized, and how it is coordinated. We also want to review the approach to decrease fragmentation and improving coordination and placing greater emphasis on the needs of our patients as it relates to patient-centered medical home, which is PCMH, which most of you are aware of. Again, as we're discussing an intro to the medical neighborhood, as you know, most of our primary care physicians, as per DISRIP, were required to obtain NCQA PCMH level 3 by March of 2018. We applaud you guys for doing a great work in achieving PCMH level 3 and many other levels by this time. Many of the goals of PCMH really rely on improved communication and coordination across healthcare providers and across systems, as I've already said. In other words, we're really asking and looking for a high-functioning medical neighborhood. So we're looking for a better flow of information across clinicians and patients, and also looking to introduce some levels of accountability in order to ensure that clinicians are participating in information exchange, which leads to better care of our patients across all continuums. Again, the objective of a well-functioning medical neighborhood really requires basic communication and coordination functions. So we're looking at a number of things that could include specialists that need to let primary care physicians know what type of routine care the patient needs, looking at primary care clinicians that need to make appropriate referrals to specialists and providing the appropriate background information that's needed in order for the specialist to take care of the patient. We're looking at hospitals to let primary care teams know if a patient has been admitted or been to the ED. We're also looking in general for primary care clinicians and other team members that need a broader understanding of each patient health care needs to assist in coordinating of all of their care and helping the patient navigate the system in order to ensure that there is appropriate treatment plans and appropriate medications that are prescribed throughout the entire system, from the specialist to the primary care physician to the hospital. Next slide, please.
So as Sarah mentioned earlier, we're putting a greater emphasis on the patient, and this includes working with community-based organizations. This may be a new concept for some, but the community-based organizations is very important in this model, so we want to discuss a little bit about their role and what we hope to accomplish. Community-based organizations are important health system stakeholders as they provide numerous, often highly valued programs and services to the members of their community. Community-based organization in this model serves as a connector to primary care offices. It's important that the primary care offices know about the available resources for the different patients' needs, and will be able to make referrals, which Latanya will get into in a moment. But let me just talk a little bit about the roles and responsibilities of community-based organizations. As Sarah said, I'm not going to read the whole entire slide. You can kind of refer back to it when you have an opportunity to do so. But our community-based organizations, we're looking to identify CDOs for possible collaboration with the primary care offices, provide educational tools and resources for staff and patients. That includes a little bit of health literacy, which I'll get into in just about 60 seconds. And also work with internal champions to make sure that the materials that you're giving to your patients is pretty much at a readable level that is appropriate for them to understand. What are we hoping to accomplish in the community-based organizations in this model? Again, improve patient outcomes and quality of care, reduce the social determinants of health barriers for patients. Latanya will get into that in a moment. And also to increase cultural competency and health literacy, not only for the staff, but for the patient as well. Next slide. So, this model, when we talk about social determinants of health, there are so many social determinants of health that is in the community, but we want to emphasize on these key indicators or social determinants of health indicators. We talk about food, education, transportation, childcare, housing, and employment. So what does that really mean when we talk about food? We're here to work with our community-based organization in terms of finding those resources to reduce some of those chronic diseases that includes type 2 diabetes, link patients to our primary care offices, to some of those fresh and fruits and vegetable programs that's out there that you may not be aware of. So that's important for us to be able to review some of those chronic diseases that we see. Education, what can we do? What can we provide here? Millennium can provide, again, that health literacy education to training and the staff, and to patients for better care management, including improved treatment adherence. So we know that sometimes with the low literacy, patients are not taking their medication because they simply cannot understand those instructions. We do have a training platform here that will work with your staff, as well as a one-on-one patient, as well as with patients if they need to know about their medications adherence. With educations, again, we're going to link patients with programs at community-based organizations to assist with translations or interpreter services and translated materials. I know some of our primary care offices work with a high refugee population. We can support you in that manner. When it comes to transportation, we can link providers and patients to organizations that will assist with patients getting to their primary care appointments. I know I'm preaching to the choir about it's important that our patients get to the primary care visit, so we're going to help you with that. What can we do with child care? We can provide the resources to patients facing the child care challenges and provide training to the healthcare staff regarding early childhood challenges and behaviors that a patient may be experiencing. We do have relationships with the early childhood community that we can tap into. So if your patient is facing, let's say, bite, the child is biting, we can help with facilitate that relationship with the child care community to reduce some of that. Housing, we can provide resources for the housing related issues as it relates to those social determinants of health. Again, employment affects everything. We're going to connect the patients to training and employment opportunities. So this is the value added for the community-based organizations. We have those resources available here and those relationships with our community to help reduce those social determinants of health.
We're going through a brief overview of the role of a case manager or care coordinator within this medical neighborhood. We would want them to supervise the interdisciplinary care by bringing together the different specialists whose help the patient may need. The coordinator is also responsible for monitoring and evaluating the care delivered, which may involve outreach and engagement, ensuring client support and education, ensuring communication between providers. Bidirectional communication is key, providing the best care for our patients, screening and tracking outcomes, facilitating referrals, supporting self-management ability, and also shared care planning, which is very important. It allows all people and organizations involved in the patient's care to be well informed of the patient's current health status. What we hope to accomplish with having care manager or care coordinator in this medical neighborhood is addressing gaps in care. Care is person-centered and coordinated, improve the client's quality of care, and provision of tools for the patient to become their own health advocate.
So the social worker's role in this model really is to promote awareness of the social determinants of health, which are things that are non-medical but impact the health, wealth, and well-being of patients and their families. Social workers add a psychosocial perspective to the disciplinary team and model of care. Working collaboratively with patients and their families, we look at their needs and preferences to help connect individuals to appropriate services. We also provide information, education, and assistance, coordinate and help arrange connections to community-based organizations, which Kim has already pretty thoroughly talked about in terms of connecting people to resources within their community, places and spaces where they can go that are more local to them, as in regards to housing, food, education, medical transportation, childcare, and employment. So the social worker really focuses on providing appropriate and consistent access to resources and information while supporting and empowering patients as they navigate different systems.
All right, so you've heard about a few different aspects that relate to the medical neighborhood and a few different things that you need to be thinking about as you are building your medical neighborhood. So right now, I just want to go over the medical neighborhood requirements in your contracts. We're going to go over the requirements in the acute care contract as well as the primary care contract. So I'm going to go over the acute care deliverables. Here, the requirement is to develop or revise a care transition policy that takes into consideration the deployment of the medical social process or risk assessment of the medical and social needs of a patient when they're in the hospital, enhanced bi-directional communication with CBO vendors, with primary care, with other specialists that you're referring patients to after they've been to the hospital, linkages with other partners. As I said, expanded CBO integration and outreach and follow-up after patients have left the hospital. So you can see what the substantiation requirements are there, and you guys already know about this, so I won't go into much detail. Next slide, please. As we're talking about assessing patients for their medical and social needs while they're in the hospital, you can see here that we are presenting you some evidence-based tools that address these specific things. You can see there are 3 tools that address the medical needs of a patient and 3 tools that address the social needs of a patient. We ask that you work to review these and see whether you're asking any of these questions or if you could adopt these tools within your assessments to ensure that we are looking and identifying patients who are at great risk for readmission. And we're all working together to reduce readmissions and admissions in our region. So these are some tools that we can use to be thinking about what we can do specifically to address needs, identify needs, and then work to connect patients and reduce readmissions as a community. Next slide, please. Just a little bit about the hospital transition of care policy. Essentially, the objective is to just help other providers understand how the patient transitions from the hospital to their office or to their setting. So you can see there, based on the hospital assessment for social and medical risk factors, those that are identified as high risk, you must ensure a few things are done for them. And you want to ensure that you're connecting them with the appropriate CBO vendors that are addressing their social determinants of health. You want to establish a thorough medication reconciliation process while they're at the hospital so they do not leave the hospital and that's not done. And as you're handing these patients off to other providers, that this is done before handing off. Establishing linkages with those partners that are listed there. Having the caregiver involved in education and on the discharge plan. And then just ensuring that there is follow-up and outreach even after discharge for these high-risk patients to ensure that there is bi-directional communication, that there is appropriate handoff to other providers and other services that they may need in order to reduce admissions. Now on the primary care side, the requirements are similar but also different. We're also asking them to revise their transitions of care policy and to think about specific things that are relating to bi-directional communication with other providers as well. We're looking for them to outreach to patients with asthma and COPD in order to schedule follow-up visits for inpatient admissions and ED discharges. And we're looking to enroll patients in care coordination, those that are eligible, and refer them to health home services for those that are eligible, in order to further help them and address social determinants of health in order to reduce admissions on the primary care side and reduce use of the healthcare system while they might not need to. As you can see, the substantiation is there, and we've been talking about these all year long. Feel free to reach out to your relationship manager if you would like any assistance with the substantiation items that are listed there. On the primary care side, when it comes to the transitions of care policy, some of you might call it the care coordination policy, or a few other terms. We're talking about the same thing here. We're not asking for you to name it the care transitions policy, but we're all talking about the same thing. We're looking for the primary care provider to deliberately organize patient care activities through intentional and effective collaboration and communication. The important piece here is the intentional and effective collaboration and communication. That is key to working together as a medical neighborhood, to reducing admissions, to ensuring that there is effective follow-up with patients. And again, this is achieved through improved healthcare delivery across the health systems. As you can see, there's some things that we're asking for you guys to consider as you are revising your care transitions, your care coordination policy. Again, they mirror the same things we're discussing in the acute care deliverables. You want to establish linkages. You want to promote bi-directional communication. You want to make sure that you're creating follow-up visits and policies and procedures, workflows that address follow-up with patients, enabling real-time alerts with Healthy Link in order to know if your patients are in the ED or have left the hospital after they were admitted, and a process to ensure that you are following up with these patients once you receive these alerts is key in ensuring that we are following up with our patients effectively. Next slide. Now that you've heard all this, I would like for us to be thinking about who is in your medical neighborhood. We've talked about the CVO vendors, we talked about social workers, care managers, and all that. This is just a blank diagram showing you an exercise for you to be thinking about who is in your medical neighborhood. Who are you currently working with to ensure that your patients are effectively connected with the services that they need to? Who are you working with to ensure that the patient is well taken care of and their medical needs are addressed? I'll just have you guys think about this as we are going through the presentation, as we're talking about what it takes to be an effective medical neighborhood. Just be thinking about this and take this exercise and bring it to your offices. Have your front desk staff think about who's in the medical neighborhood at your offices. Have your nurses think about who's in your medical neighborhood. This is how you start to identify the gaps and how you need to be creating better relationships with other providers in order to promote a better medical neighborhood for your patients, a better medical neighborhood for our community. All right, next slide.
We'll be going into a bit of detail of the pharmacist role within the medical neighborhood, specifically within the asthma COPD patient population. So during care transitions, patients are actually most vulnerable to medication errors. Many patients go home with a very overwhelming discharge summary and don't know what's discontinued and what to continue. So the pharmacist can play a role with educating the patients. Specifically within the hospital, they can ensure proper prescriptions are in pre-discharge and review medications and devices, provide counseling on inhaler technique. They may also assist in the transition of care post-discharge if they have the staffing capacity to call the patient, follow up, make sure they pick up their prescriptions, make sure they have an appointment scheduled with their PCP. Within the community or within the ambulatory clinic with a clinical pharmacist, the pharmacist may complete medication reconciliation or medication adherence assessment. If the patient's not adhering to their meds, identifying those barriers, can they benefit from blister packaging or 90-day fills or setting an alarm on their phone to remind them to take their medications. There's also disease state education. Device counseling, so teach-back method is crucial. Studies actually from Rice University showed that 70 to 90% of patients are not using their inhalers properly, so there's definitely an opportunity to educate the patient. Provide medication recommendations based on evidence-based guidelines. Address barriers to care, whether it be transportation, lack of refills, or side effects. Encourage smoking cessations, offering pharmacological options or non-pharm options. Recommend needed vaccinations, specifically for the asthma and COPD population, either the influenza or the pneumococcal, and completion of screening assessments, like the COPD assessment test or the asthma control test. This will assess the patient's severity of symptoms and help guide therapy selection. With the pharmacists involved in the medical neighborhood, what we hope to accomplish is addressing gaps in care, improving patient quality of care, reducing exacerbations and symptoms, and provide patients with the tools to become advocates for their own health.
So as Ezra is speaking, we're referring to the asthma and COPD focus that we have asked our primary care physicians to place as we are thinking about the medical neighborhood this year as part of your MPA requirements. We have been having these discussions with you about following up with patients that have been to the ED or admitted for COPD and asthma. And Ezra is speaking to the role that pharmacists can provide as we are reaching out to these patients, as we are reviewing their medical and social needs, and the role that pharmacists can provide as you are thinking about what to do with these patients after they've been to the ED or after they've been discharged. And furthermore, even what you could do with these patients as they're in your practice before they've even gone to the ED or even been admitted. What are some things that you could be thinking about when you're taking care of them? What are some things that you could place focus on? So I just wanted to make sure we discuss that a little bit more. And then we're going to be going forward and looking at some other key relationships. So when it comes to behavioral health and the key relationships that you have with your behavioral health professionals, the role and responsibilities for those professionals are to provide assessment and treatment and strategies to assist in the overall well-being of our patients. Approximately 70% of primary care patients in Western New York have some comorbid behavioral health conditions identified with a physical health condition. As you already know, a lot of our patients are diagnosed with depression or other behavioral health diagnoses. So the objective and really what the behavioral health professionals hope to accomplish is to effectively collaborate with the most and best care plan for the patients and identified with or suspected for having behavioral health issues. Again, they are also promoting bidirectional communication as we've already been discussing. They're looking to obtain appropriate consent in order to share information that's needed by the providers. And then they hope to share physical and behavioral health diagnoses and treatment plans with you. And the ultimate goal is to ensure a complete array of services for the patient who have these conditions and just ensure that the most appropriate services are received. And for the specialists, they want to ensure effective communication and coordination and integration into the PCMH practices, again in a bidirectional manner. They just want to ensure that there is timely consultation, ensure efficient and appropriate and effective flow of necessary patient care and information, and then guide the determination of responsibility in co-managing patients with the primary care physician, because you all are taking care of one patient, and so how do you all work together in a better way to provide the best possible care for the patient?
When we're talking about supportive medicine and palliative care, this is really kind of two different models. So there's the supportive medicine methodology you can deliver yourself within your clinic and your practice, and then there's also the downstream supports such as a palliative care doctor or hospice that you can refer to throughout the patient's course of illness or lifetime. So really the roles and responsibilities of a supportive medicine service is to relieve the suffering of patients and their families by the comprehensive assessment and treatment of physical, psychosocial, and spiritual symptoms experienced by the patients. So within your practice, if you have a really good integration of supportive medicine materials and understanding within your patient care plans, possibly you'll be identifying goals of a patient that are more psychosocial or spiritual, and that will lead you to maybe make a referral to a patient support group or a Bible study or something like that over another test or another treatment if the patient doesn't want to pursue active treatment of their condition, if they've kind of embraced the values and the life that they've had and they have a different course that they would like to pursue. A lot of times we don't have that level of understanding when a patient is dealing with a chronic or terminal illness. And unfortunately, we see these people in and out of the hospitals and, a lot of disjointed care, and no one is getting at the root of, what does this patient truly value and what do they want to spend their time doing. So I think just having that holistic patient approach and being able to understand what the patient wants and where do we go from here will really help really create these holistic care plans and really expand that referral network even more when we start talking about integrating churches and integrating support groups and other non-traditional referral entities. So objectives, you know, we really want to provide thorough patient education and advanced care planning, and not only upon the diagnosis of a terminal illness such as cancer, but really any chronic condition that is expected to increase over time or get more severe, or a patient will lose functional ability over time. So having these conversations early and giving patients and families kind of indications of what could be to come and how are we going to plan for the what ifs really goes a long way, instead of, you know, waiting until you get to that point and having to make difficult decisions without the foresight. Assess patient life goals to determine which treatment regimen fits within their wishes. Just because we have amazing technology here in the United States doesn't mean that everyone wants everything that's available. So we really need to determine what does the patient want for their life and for their health care. Increase comfort measures and family support as the patient's symptoms intensify if they desire and they approach end of life. And then after the patient's death, you know, being able to focus on bereavement and support of the family, and that's where hospice really does a great job with that. But if you're working with a patient's spouse or you're also, you know, their clinician, I think this last bullet will really help to change the culture that we have around end of life here in America and the fear of dying. People don't want to discuss it because they've had negative experiences with it throughout their family. So the more we can really focus on, you know, having deaths with dignity, I think this could really shift the paradigm that we're seeing here in America around this topic. Next slide, please. Caregiver support. This is one that is commonly overlooked. You know, we really need to make sure that, especially for people who are primary caregivers for debilitated patients, we need to make sure that we are looking out for them and that we're linking them with community programs to enhance their understanding of their loved one's disease, what the treatment options are. We need to provide them emotional support, facilitate opportunities for advocacy, and then also provide opportunities for respite so they can care for their own health. Because we know once a caregiver ends up in the hospital, that's 2 hospitalizations, because the person they were caring for will most likely follow them right along after. So objectives here, we need to make sure that caregivers are involved in medical decision making and appointment scheduling. They really should be in attendance to all appointments and have a thorough understanding of what the treatment options are, what the impact could be on a loved one's health or cognition or behavioral health, feelings of you know, depression, any of that sort of thing. Especially for patients with low health activation, we need to have a knowledgeable, trusted member to hold patients accountable for the care plan that's developed in your office. Having someone being able to follow up with them and really make sure that they're hitting those targets that you're setting for them at their appointments is really crucial for maintaining chronic conditions in the community healthy. Ensure caregivers are linked to support groups and respite services to prevent caregiver burnout. And ensure caregivers are linked with community-based organizations who could provide advice, tips, home modifications to keep their loved ones safe and healthy. And then we also have the post-acute care entities. So by nature, their name is post-acute. So I think it's been kind of common sense that someone will have a hospital, they will have a hospitalization, they're in acute care, and then following acute care, you go to post-acute. But more and more we're seeing these entities able to care for patients whose health is declining, but they haven't reached the point where they need to have a hospitalization, yet they could benefit from a higher level of care. So we're really trying to encourage these collaborations with skilled nursing facilities and home care agencies and primary care groups that, you don't necessarily need to wait for someone to decline enough to have a hospitalization, to then go to a skilled nursing facility and then have home care to end up right back in your office. If you see that a patient is declining while they visit you in a primary care office, or if you're changing medications and you need someone to follow up with them in the home, you could refer a home care service to start with that patient immediately. They don't need to have a hospitalization. There's a lot of programs now too for direct community admission programs into skilled nursing facilities. So if a patient has CHF and it is exacerbating and they need an increased dose of their Lasix, or they need therapy services because they are unable, due to swelling or weakness, they're unable to ambulate or dress themselves the way that they were before. These patients can be admitted directly into skilled nursing facilities a lot of the time. So that does take some arranging on the primary care office behalf, but you're going to avoid an emergency room visit, you're going to avoid an observation or a hospitalization stay. That really puts the patient at risk for, excuse me, developing other infections or having an even further severely decline of their functional status. So objectives here are we really want to stabilize the medical condition of a patient to a level where community management is safe and appropriate, ensure compliance and understanding of medicinal and treatment regimen, provide ongoing education and support, so for someone with wound care or IVs or G-tubes, any of that type of treatment that needs some intervention and some education, these groups are great to help provide that. And then provide linkages with community-based organizations to assist with social determinants of health and caregiver support related needs. So if a patient does end up going to a skilled nursing facility, we're working with them as well to really make sure that they have these thorough discharge plans and that they are looking at what are the barriers and who can we connect with in the community to really make sure this patient has a good support system to keep them, healthy and safe in the community.
We'll also be discussing the role of value-based payment. Most of you have had discussions with us regarding value-based payment, and as we have been getting you thinking about what your value-based payment transition plan is. And of course, this is a natural next step for the medical neighborhood. As we're discussing better care across the system, this is the foundational work that sets us up for value-based payment. We're looking for close partnerships and good data sharing across all continuums, across all systems, and this will give us the foundation to be a successful organization, successful practices, successful systems in the VBP environment. So the objective really is to have a shared laser focus on a cohort of patients. And then again, the objective of value-based payment is to be able to track and manage patients across the neighborhood. We've been talking about bidirectional communication a lot across different partners, whether they're in the hospital, whether they're in the primary care practice or a behavioral health agency. We want to make sure that you all know where your patients are and how they're being managed, and that information is being passed along to you about their care. Being able to utilize tools for risk stratification. We mentioned those tools in the acute care section where we provided some medical and social evidence-based risk tools. You want to also think about, on the primary care side, what tools you could use to risk stratify patients, to identify your high needs patients that need to have care coordination and care management across all of these settings. Value-based payment will help us develop programs and interventions with our neighborhood partners to impact shared outcome measures. So we're all going to be looking at how well we're managing one patient, whether they're seeing a specialist, CBO vendor, a primary care physician, a pharmacist, a community health worker. We are all working together to improve this patient, and how well are we all communicating? How well are we all co-managing this patient? And then looking to create quality and performance governance with participation across the neighborhood. So again, there's also interactions as we're thinking about the medical neighborhood with PCMH and New York State PCMH for those clinical and non-clinical interactions between everybody across all systems. Again, it could take a lot of different forms. There's a pre-consultation exchange where you are prioritizing care and clarifying the need for a referral to different people in the system, whether it's specialists, pharmacists, or other people. We're looking at formal consultation to deal with discrete questions and procedures that address their social situations. And then co-management. Many of our providers are working with behavioral health providers to co-manage patients, or with other specialists to co-manage patients. with shared management of disease, with shared management of social needs with the patient, to CBO vendors who are going out there trying to find your patients, trying to address the social determinants of health. And again, with the principal care of the patient for a consuming illness for a limited period of time, and being able to transfer patients to specialty facilities for the entirety of their case.
So the medical neighborhood, I'm sure everyone's heard of the triple aim, but maybe you haven't heard of the quadruple aim. So we're really looking at improving the patient experience of care, including quality and satisfaction, improving the health of populations, reducing overall costs of healthcare, but also improving provider satisfaction. I'm sure when patients are coming time and time again back into your offices and seemingly are not activated in their health care, or have had another hospitalization, and you've again, reworked their file and reworked their medications and nothing seems to be working, I'm sure that really can wear on your provider groups and all of the staff, everyone who's touching this patient. So I think that if we can all work together and really see these patients thrive and have better outcomes, we're going to feel much more fulfilled and much more satisfied with our jobs as healthcare clinicians. So here is a very, I will say, busy medical neighborhood. We have a lot of referrals going on here, which is great. Not all medical neighborhood models need to look like this, so don't feel like you need to have 10 referrals for each patient. But this is just an example of some of the different types of referrals and services and outcomes that different entities can play as you're developing a model for your patients. And, at the top there you have community and you have social determinants of health support. If one of your patients is pretty healthy, but they have 3 or 4 different SDOH needs, if they need housing, if they need food, if they need some assistance with, child care, you might have 3 different, provider groups as referrals here just for social determinants of health. If you have care coordination through Millennium, or if you're linking with a health home, a lot of times they can help with a lot of that too. So it will vary patient to patient. We have durable medical equipment there, DME, so keeping patients stable in their home through providing different modified equipment or different types of home modifications to prevent falls and have increased functionality in the home for patients. You have diagnostics, data exchange, so those are pretty well intertwined there because a lot of the diagnostic procedures occurring in Western New York, all of that data is available on HealthyLink and available more timely to our provider groups, which is great. Behavioral health, post-acute care, health homes, hospitals, pharmacies, specialists, everything that we really touched on today. And when you think about it, you can think of the little lines in between each of the blue rectangles as symbolizing bidirectional communication. So, we don't want to be doing all of these, one of the things that we've gotten better at is trying to coordinate care and think more holistically. However, we tend to coordinate in silos. So we have the behavioral health team coordinating care and looking at social determinants of health and what they can do for that. And then we have, the primary care physicians doing that as well as the health homes. And they're all kind of coordinating this great care, but they're all doing it within their own teams and not discussing it with one another. So there's a lot of either duplicative coordination going on, or there's coordination that is actually hindering one from exceeding or one from excelling. So really, if we can put together some bidirectional communication processes and protocols and be working as a team, it'll be much more efficient and much more understandable for the patient. When a team has more than one quarterback, it gets confusing as to who's responsible for calling the shots. And that's why we really tried to put primary care in the middle of all of our medical neighborhood models is, you truly are the quarterback of this patient's, this patient's care plan. So we need to make sure that everything's being tied back to primary care and, that all the coordination is really stemming out of that group.
Next slide, please. As we are wrapping up on the different things it takes to develop your medical neighborhood, I just want to remind everybody that you can submit your questions through the chat function, and we're going to have some time for questions if you have any. But just to wrap up everything we've been talking about, As you're developing your medical neighborhood, you want to be thinking about facilitating work groups of multidisciplinary providers and community-based groups. You want to develop protocols, workflows, procedures for warm handoffs, and information sharing between you and specialists, you and behavioral health partners, you and community health workers. You want to bring evidence-based informed care models into your settings, whether that's addressing social determinants of health or medical assessments. You want to provide education and training on provider skill sets, as we discussed, advanced care planning, and then formalizing collaborations and expectations between you and other providers. So that's between primary care providers and specialty providers and CBO vendors. You want to make sure that you are thinking about how to collaborate together, identify the needs that are needed in each and every person's area, how you could all help each other to address specific gaps, and how you could bring other individuals into your collaboration, into your agreements to help address specific gaps that you identify moving forward. So what are the next steps for this medical neighborhood in our region, in our community? While patient-centered medical home forms the core of the medical neighborhood like we discussed, the extended network of specialists and community partners is just as critical to improving the health of patients. And in order to build a successful medical neighborhood, we all need to be practicing, and especially the primary care practices, need to be formalizing collaboration and expectations, as we said, between different systems. You want to make sure that you're thinking about who are the community-based organizations in your area that are providing food, housing, transportation, childcare, and who are your patients accessing the most in your area. Who can you partner with to bring in these services firsthand for your patients, so they're not sourcing them outside of your office? How can you bring this to the forefront of the patient while they're with you or after they're discharged? What hospitals do you need to be collaborating with more to address bi-directional communication at discharge, or while patients are in the emergency department? Different things like that. So these are things to consider and things that we will be discussing as we're moving forward together and as we're building the medical neighborhood. I just want to highlight all the relationship managers here. Please feel free to reach out to your contact if you have any additional questions regarding the deliverables and substantiation, or any other things that you would like us to work on or help you with in terms of thinking through the medical neighborhood. So we're just going to have a brief time for questions. We currently have a few different questions we're going to look through. Just give us a moment. Well, we don't have any questions at this time. We're going to open up the line, and just if anybody has any questions, feel free to ask them now, and we're going to wrap up if there's no questions. Just so everybody is aware, you're all unmuted, and we're opening up the line for questions if there's any.
Alright, since there seems to be no questions, if we receive any via email, we can put together a frequently asked questions or an FAQ document and make sure it gets out to the entire group so everyone has that messaging.
All right, thanks for joining us. Have a good rest of the day, and we hope to see you soon for another webinar.